All right, so let's go ahead and get started. I want to be respectful of everyone's time. So welcome to the Society of Thoracic Surgeons General Thoracic Surgery Database. This is our quality improvement series for GTSD. And again, the focus is on reducing readmission rates. Today's Wednesday. Is today Wednesday? Yeah, today's Wednesday, October 23rd. So whew, it's been a long week so far, people. So again, thank you everyone for joining us today. In terms of agenda, just welcome everyone onto the call today. And in terms of our panelist side, just a small group of us today from the STS. It's just myself and Carol Krohn, director of the STS National Database, Nancy Honeycutt. She's the database manager for the adult cardiacs. Oh Lord, the adult.
It has been that kind of day and week, and oh Lord,
Yeah,
you got this, Leanne Jones.
yeah,
Got this.
you got a new title, Nancy.
I kind of like that. It's
Database manager.
shorter.
The database manager for adult cardiac, Intermax, and PDMax. And then we also have Emily Conrad, who keeps us all straight on the quality side. Emily handles our STS audits, and she also handles all of these webinars for us. So thank you, Emily, for joining. And we have Ruth Riley, our GTSD consultant, whom I could not do this without. So thank you, Ruth. So again, I'm just going to we're going to have review a little bit of readmission data, and I'm going to also just give a brief introduction, circle back to the initial kickoff call, just to cover a little bit of our introduction that we did last time, because we have some new people on today's webinar, so which welcome. And then we'll finish up as usual with our Q&A at the end. So be sure to submit your questions via the Q&A button. We also have that raised hand function enabled. So if you just like to ask your questions, we'd love to hear your voice. We can unmute you. Just make sure that your microphone is enabled on your end. And again, just please put those questions into the Q&A. It looks like we have the chat closed now, so it's just a lot easier for me to manage all the questions if they're in one location. All right. So again, the STS National Database Quality Improvement Series, what are our goals with this series? So our overall goals are to show the value of the database outside of just getting your feedback reports and those star ratings. So again, there is a lot more value in the STS than simply just getting those reports back. And our goal here is just to show how we can utilize the STS National Database. Also, we want to show how important you as the database manager are in abstracting these data. We couldn't do this without you. And so we definitely want to show how important you all are as the data managers. We want to make your STS data actionable. Also, we want to help decrease cost. Most importantly, we want to be part of a national team effort, and we want to because it's awesome to work towards something together. So those are our main goals for this quality improvement project. And we are so thankful that you're here, and we look forward to working with you all and showing the value of this database outside of just getting those feedback reports and those star ratings. So readmission rates, why do we care? Again, I covered this in our kickoff call, but I think it's important to go over this information briefly again. Why do we care about these readmission rates? So it's been shown that the readmitted patients do have the higher complication rates, higher rate of infection, increased rate of mortality. They tend to have those longer recovery times. We see increased opioid utilization and overall quality of life impact via patient-reported outcomes. Why is it important to our healthcare systems? Those throughput challenges, complications, and readmissions increase the length of stay. We have the increased costs associated with these complications and the decreased reimbursement risk, the CMS Hospital Readmission Reduction Program. So right now, I think that CMS Hospital Readmission Reduction Program is in effect for, with ACSD, and we, certainly expect it to be coming down the pike for GTSD as well. So those readmission rates and why we care about reducing these readmission rates. So how are we going to do this? First, what we want to do overall is nationally decrease readmission rates for our lung cancer patients. We will measure this by looking at baseline data that will be pulled from our most recent, from the Spring 24 Harvest Analysis Report. Mean readmission rate and mean length of stay will be reported. We'll analyze the data using the harvest reports. Sites will implement the processes at their site. Sites will implement processes to decrease readmission rates. We'll provide education and support for these processes. We're going to engage site leaders who have already accomplished decreased readmission rates, and we'll provide education on webinars and be available as resources. And then we will track this monthly to see improvement nationally. So first, we just want to take a look at the data. We are going to review the readmission and complication rates by institution based on volume. And then moving forward throughout this series, we'll continue to take a deeper dive into the readmission rates. We'll look at specific postoperative events and postoperative length of stay. So for the remainder of this presentation, I'm going to turn things over to Ruth so she can walk through a couple of graphs, and you will take it from here.
Hey, everybody. So the purpose of these graphs is to just give a very high level overview. At future quality improvement sessions, we'll dig into the data a little bit deeper, do a better statistical analysis, give you a lot more information, but really just wanted to start with a high level overview at how we were looking at the data. So this is using the Spring 24 Harvest data set. And this first graph represents sites with 30 to 69 records in that harvest period. This graph, the blue bars are percentage of post-operative events coupled with percentage of readmission at 30 days. And so the average readmission rate for this group of sites was 8.2% with an average post-op event rate of 33.4%. I'm going to go to the next slide, Leanne. I included these slides in the deck. We're really not digging into length of stay so much with this quality improvement initiative. However, we wanted to keep an eye on length of stay just to make sure that we didn't decrease readmission rates at the expense of increasing length of stay. Interestingly, median length of stay for every site is 3 days. This graph displays readmission percent at 30 days and the average post-op length of stay for each one of these sites that were represented in the previous graph. And again, this is just to sort of keep an eye on it. We're not doing a length of stay project. Next slide. So for our sites with 70 to 145 records in the Spring 24 harvest, they had an average readmission rate of 7.6% with an average post-op event rate of 30.4%. I think it's important to note, and I should have mentioned earlier, we're looking at all post-op events, just not things that fall into the major morbidity category in the harvest analysis, but it's an all-in post-op event rate. I'm going to go to the next slide. Again, this is just the length of stay data for the same sites to keep that in the back of our minds. Go to the next slide, please. And then this is the readmission and complication rate data for sites with greater than 145 records in the Spring 24 harvest. For these sites, average readmission rate is 7.1% and average post-op event rate was 29.5%. So if you look at the three, and I wish they were all on one screen, but it's too much data to put all together. If you look at the three sites sort of compared side by side, you'll see that sites with the lower number of records have both a higher postoperative event rate and a higher readmission rate, which is what I would have expected. I would have expected to see those two sort of go hand in hand, not necessarily related to number of records. But we had talked in a previous webinar about the paper published by the Michigan Collaborative, and there's also a readmission rate paper that was published by Dr. Brown related to lobectomy. readmission. And both of those papers supported this concept that as complication rate increases, so does readmission rate. And that's exactly what we saw in this data set. So I thought that was reassuring. So now we'll just need to sort of dig into our data set, the bigger data set, and think about what postoperative events are most significantly contributing to readmission rate, and then start digging into those post-op events so that we can reduce those and then thereby hopefully reduce readmission rate. I'm going to go to the next slide, Leanne. Oh, and again, this is just the length of stay data to keep in the back of your head. If you want to go to the next slide. So we wanted to sort of ask the group some questions, have some open conversation. Leanne, I don't know, is it possible for people to unmute, correct? Like if they raise their hand, they can unmute after
yeah,
we do the
absolutely.
survey? Okay.
Yeah, absolutely.
So we're going to run these as polling questions, but then would love to have some conversation if anyone's interested in sharing more than a simple yes, no, or I don't know on any of these questions. So the first question, does your site have an enhanced recovery program for either pulmonary resection or lobectomy?
Oh, I don't think you can see the results, can you, Ruth?
I cannot.
Okay, I'm sorry, I didn't
Hold
make
on,
you-
I'm on it. I'm on it.
Oh, good job, Carol Chrome.
I was going to try to live stream our thing onto our Facebook group, but I'm trying to figure that out. So
Fancy.
I know, but it's not fancy yet until you can do it.
All right, I'm gonna go ahead and share the results. So Ruth, you can see them.
So it looks like we have a lot of I don't knows and a significant number of no's. I think one of the considerations, one of the things that we're thinking about possibly having as a topic in a future session is either successes or failures of enhanced recovery program implementations at various sites. So if anyone is a yes and would be interested in sharing how your site set up their enhanced recovery program, I would love to hear from you. You can either email Leanne or I, and we'd love to have you and your surgeon or your surgeon share their program with us.
Absolutely. And while we're waiting for that, Ruth, just a quick question, just to clarify, in the graphs, I'm just going to go back. What were the X and Y axis numbers?
Oh, I'm so sorry. I should have labeled them better. So the numbers on the left-hand side are percentages. So for example, site 122 had so the very first column on the left had a 10% rate of postoperative events and a, I don't know, 1% rate of readmission for the same patient population. Site number 122 is just a random number that I assigned. It doesn't correspond to anything. I know what everyone's site number is. Carol, am I allowed, if anyone asks, am I allowed to share? I think probably. But
No.
no, oh, okay,
No.
never mind. So I can't tell you what site you are, but it's just a random number I assigned to sites.
And then also, I think, when we were looking at this Ruth for the population, we didn't include any sites that didn't meet the lobectomy or the resection threshold of 30 eligible records for that population. So I don't know, just wanted to clarify that as well. And
Thanks for that clarification.
yeah, no problem. And then this is just because me being non-clinical and not working on a hospital ever, for, when I know we had a lot of 40, almost 50, percent that didn't know if their hospital had an enhanced recovery program. Where would you go to? I know this is probably a dumb question because I'm not clinical, but where would you go to find out that information? Like if they want to, where would you start?
I would start with your surgeon. Your surgeon, enhanced recovery programs have a very specific set of criteria for patients in the preoperative period, and then in the intraoperative period and the postoperative period. So your surgeon would have been involved either in setting that program up if they've been at your institution long enough, or in participating in that program if they joined the practice after the program was already set up. And then it's usually pretty collaboratively put together because, again, it crosses so many different stakeholders. So your OR team needs to be aware, your office clinical team needs to be aware, your surgeon's office clinical team would be aware. And then whoever does your preoperative teaching at your institution would be aware of all of the different elements of that program.
Yeah, I would
And
like
it's
to,
usually, oh, go ahead.
sorry, it's
No,
Nancy.
please.
I would just like to also say that anesthesia is very involved in that process
Yeah,
of enhanced recovery. So that's another place you could look with your anesthesia partners.
agree.
And for the grass, what population did we use, Ruth? It wasn't just lobectomy.
Correct. So because we wanted to allow sites to be able to access similar data whenever they wanted to, we wanted to use the same patient population that was available in IQVIA. So this is the pulmonary resection patient population.
Awesome. And a question from Christina. What does an enhanced recovery program entail?
Sure. So enhanced recovery programs, there's a bunch of very structured requirements, but just off the top of my head, I'll list some that I'm aware of, and Nancy, feel free to throw some in from your very successful program as well. But it's one of the things that they looked at, like historically patients were kept NPO or with nothing by mouth for 12 to 24 hours essentially. And based on research, there was determination that that was not necessary and that patients actually did better if they had something to drink within 4 to 6 hours of their procedure. And so now patients are required to drink something in that period in some instances. Another thing that we looked at was whether it's helpful for them. We give patients like a specific protein shake that they drink within so many hours of their procedure because the protein in that was found to be helpful for recovery. In terms of postoperative requirements, it's a lot about pain control and how pain is controlled. I guess during the intraoperative and postoperative period is a large part of enhanced recovery programs often. What else can you think of, Nancy?
I was going to also add preoperatively, prehab, like getting your patient totally optimized for surgery. You mentioned the nutrition, but also exercise and mobility. And then also optimizing their labs, particularly hemoglobin and hematocrit. That was one thing that we worked on. And
Dawn,
then also,
oh, I'm sorry. I was just noticed Dawn, what you're referring to now, Nancy, Dawn had pre-admission testing. She had stated would be included in that enhanced recovery.
right. Yep.
So, Catherine, can I do the poll again? Can I do that? I can relaunch that poll. So I think now that we have, we have a little bit more information about like what actually is an enhanced recovery program. So before I launch the poll, would ERAS be included in enhanced recovery program, or is that something different?
That's the same thing.
It's the same.
Okay.
Yeah.
Okay. All right, cool. And thank you, Amy. It was an excellent. I'm totally a non-clinical person, so and I do know, we do have a lot of non-clinical data managers, so I'm not scared to ask
What does ERAS stand for?
Enhanced recovery after surgery.
Okay.
There you go, Leanne Jones.
There you go.
We just need to understand what the acronyms stand
Yeah.
for, then it helps us.
Yeah. Donna had her hand raised, so Donna, I was gonna unmute you, and you should be able to ask your question or contribute.
Can you hear me?
Yes, ma'am.
Okay. I was just going to say, for those who are unaware or don't know, I'm always able to find my ERAS order under order sets in Epic anyway. Also, the physician a lot of times mentions it in his H&P.
Okay.
Yeah.
Excellent. So I'm going to relaunch, actually, let's continue. I can relaunch the poll. So I'm relaunching our question 1. Does your site have an enhanced recovery program? So we'll see how our results differ. It's a great
It's also
conversation.
called ERAS. ERP is the abbreviation for Enhanced Recovery Program. I can't think, sometimes it may loosely, I wouldn't consider pure prehabilitation the same thing, because I think that's really only the before surgery piece and not the after and during surgery piece, but prehabilitation can be part of the overall program.
Nice. Yeah, so our results, yeah. So now we're about 48%, we're yes, and 28% no. So we're down to 23% that do not know. So good. That was a great question. Excellent. All right. So next. Oh, Donna, did you have any more? Did you want to say something else? Okay, sorry. All right. Our next question, Ruth.
Yes. So the next question, we were curious to know if your site has instituted a targeted quality improvement project looking at one of the specific post-operative events. So for example, has your site done a targeted project looking at reducing air leak rates? I think is a pretty common post-operative event that a lot of sites have tried to manage in different ways.
Still going? All right, it looks like we're slowing down just a little. Every time I say that, our numbers start jumping up really quickly.
Giving everyone anxiety at the end. They're gonna the fear of missing out, right?
I know, right? Okay, we're gonna end it here and share the results. So we look like so about 31% of our participants here do have a targeted QI project looking at one of the post-op events. 46% no, and then 22% I don't know. So those of you that do, would you be willing to talk to us? So, but yeah, for those of you that do, we'd love to have you join our webinar so we can learn from one another and learn, what you're doing at your site. So feel free to raise your hand and let us know. We'd love to hear, what you guys are doing at your site. Don't be scared. We don't bite. We're friendly over here. We'd love to, learn more from you and hear what you all are doing. How about your site, Ruth? What are you guys doing?
Oh, I use my
I know
example
Michigan.
already, Leanne. Air leaks is always our bugaboo. So we've definitely looked at that one before. And I think too, I'm part of the state of Michigan, and I think the state of Michigan has some pretty unique quality improvement infrastructure. And so there are different projects that are looked through or worked on through the state of Michigan. So like lymph node resection, for example, has been looked at. I don't know if Elise is on here. She can probably share other state of Michigan QI projects that we've done. Oh, there's Elise. Can we unmute Elise?
Of course. You should be good, Elise. There you go.
Hello. Can you hear me? Okay.
Yeah.
Yeah. So like Ruth said, we do have a unique infrastructure, and we have 21 participating sites within Michigan, and we all kind of work as a group and look at our data unblinded together quarterly. So right now we're looking at the 3-in-1 standard for lymph node staging. We're looking at referrals to med-onc after surgery for certain overall pathologic stage cancers. And we're looking at length of time from surgeon consult to getting into the OR for certain stage cancers. So we have a couple projects going on, and then some of the post-op events, we review it quarterly. So like air leaks, and then we talk about, what kind of atriums are you using, and what do you do in the OR, and how do you check for air leak before you let them out. So we have a number of projects always going on.
And I think what's helpful that the community that Elise has really fostered in Michigan is that we're all in this together and we're all learning this together. We're not all quality improvement experts. And I think, you know, the majority of us, based on this poll, haven't been part of a targeted quality improvement project looking at a post-operative event before. And the goal is to really create a community where we can work not only on targeting a specific post-operative event, but work on learning how to do quality improvement projects together.
Exactly, yeah. So like
Can
you
we
said,
do an,
yeah, go ahead.
can
Carol.
we do another poll?
Sure.
This is Carol. Now, I got lots of questions. Can we ask, I don't know if we have a general poll here. Hold on one second.
I think we did.
Let me go back here.
Do.
Oh, maybe are these just say yes, no, I don't know, are the choices. Could you rerun that poll, Leanne?
Yeah.
My question is, do you feel that you have power or influence enough to, or the resources enough to initiate a quality improvement project? Are you the right person, or is there somebody else at your hospital who who has control over that and you're maybe not so much involved? Don't read the question, just not the one on the screen. It's just, that's helpful. So just wondering how, if you think that you are the right person to be, or you have the ability to initiate QI projects or run QI projects, or yes, or if the answer is no, then you would need to be working with somebody else at your facility to run QI projects. Okay. So it's pretty split.
Yeah.
I think that's the other important thing is we want to make sure that we can give you all the information, but we also want to make sure you're able to communicate with the team that's able to institute QI projects at your hospital or at your site and get them involved as well about the importance of it. And if there's information, Ruth, if there's information that we can share with the attendees that show the value of participating in this national quality improvement project, I think that would be really helpful to get buy-in from those people. And then we also, you know, if you've never been involved with a quality improvement project at the hospital level before, there's certain steps we have to consider in the quality world, like who do we work with, who are our stakeholders, what's the benefit, what's the return on investment for them, is there going to be a cost associated with this, how can we keep the cost as low as possible, who's going to help us push it forward to get the right resources, the right people, and to get a team surrounding us to support this. And what I learned from working at the hospital is sometimes we think that it's much harder than what it really is. If there is, hospitals are really focused on quality right now, and it's a very good thing for improving the outcome. So there usually is a quality department and somebody who's in charge of that that's reviewing all of the bad cases at your hospital. And you might not know that person, but the person's there, and they usually care a lot about what's going on. They know the bad cases like the back of their hand. They're meeting with the surgeons and the teams to review them. It's really important to get to know that person and kind of start an alliance with the quality department if you're not already part of the quality department from the data abstraction side. And usually the director or VP of quality will be one of your biggest allies when you start working on this national quality improvement project. So if you want to invite them to the webinars, you certainly can loop that person in, let them know what's going on, or even just pass along the link to say, hey, STS is really focusing on improving this nationally, and we want to be a part of it. You know, I have access to the data. How can I help you? How can I help your team in the quality world make this a reality for our hospitals? And usually the quality person will want to sit down and think about well, what are we talking about here? How much resources are involved and who's going to be the best person? And usually it ends up, you're going to see probably in a lot of our presentations when we talk about post-operative events, a lot of this falls on nursing. Even though we think our surgeons have a lot of power, you'll see a lot of the projects that are initiated somehow always fall in the hands of the nursing, the bedside nurses, to take some type of initiative in caring for that patient or recognizing things faster, or, we're talking about failure to rescue, recognizing when the patient's, maybe not going in the right path or is moving as quickly as we think they should be in the positive direction. So nursing usually is going to be the number one advocate. And on the nursing floors where these patients are cared for, there usually is some type of charge nurse or somebody who might be in charge of instituting new policies or ensuring that they usually have nursing governance. So ensuring that the governance team, when they meet and they're reviewing all these policies, that they're involved somehow. So usually somebody in each department, a nursing person, usually is involved in the governance structure of the hospital when it comes to policies. So that's another advocate you would want to look at. And everybody from that side, the quality, the nursing governance side, they're very focused on improving patient care and making sure that bad things happen less frequently and that the patients are receiving the best care they can at your institution, because it makes both the patient and the institution feel good when we have good outcomes. So I think we'll focus on some of that. And if you've never been part of a quality project, Ruth, myself, Leanne, we're here. Reach out to us and we can share some resources. The other good thing is reaching out on the STS Data Manager Facebook group page, meeting with peers, and don't feel ashamed if you've never, or shy or anything, never done this, because there's time where I've never done a quality improvement project, or Ruth hasn't, or there was
Leanne's
a time
first. I'm
Leanne
learning a
is
lot through this.
learning.
Yeah, so
We've all been the first time doing something like this. Even Michigan, right? Who's a phenomenal when it comes to quality improvement in the cardiothoracic space. They even had to start somewhere. So we're all starting, but the whole idea is that it's for the better of the patient. So
And to speak for Michigan,
yeah,
we had to start somewhere and we're still learning.
yeah.
I tackle things that I'm like, oh my gosh, I don't know how to do this. I don't even know where to start. The first thing you do is just ask other people, ask questions, put it out there.
Yeah, that's a good point. So do it on the Facebook group. What a better and non-judgmental way to do it. We're all on the same kind of boat with the same goal. So, and that's great feedback. So I just wanted to put that out there. Don't feel weird or shy or anything asking questions. Make sure talk to the people at your hospital. If you're not the one who's in charge of quality or able to initiate a quality improvement project, talk to your director or talk to some of your peers within the other departments, and see how you can. Your CNO at your hospital will probably be a good resource to wanting to direct you to the right person to talk to when you're talking about these things. So I guarantee you probably will get pushback, but if you find the right people to be your allies, they're going to help you get through it. So, okay.
Yeah, and
I'll get off my soapbox now. I love quality
good.
improvement projects, guys. I think we're so strong together, and even though we're a small group, we have a lot of ability to make good positive change. So
Yeah, and it's exciting, for obviously, GTSD and, this is, and with ACSD, we've never done the quality improvement projects before. So, this is new for all of us from the STS side and working all together in this aspect. So it's exciting, and, we want everyone to be involved, and we want everyone to work together and learn from each other. So and like I said, a lot of us are non-clinical, several, data managers, and there's a high turnover for the data managers. So I think it's important, everything you just said, Carol, was a great explanation and so important information. So thank you. You can get on your soapbox as much as you want. It's a good soapbox to be on.
I'll tell you, thanks, Leanne. I'm really good at getting on my soapbox. I'll tell you a story. When I started in the hospital in quality improvement, originally I was started in radiology, and then I worked for the heart surgeon's office, and then I went over to the CV telemetry unit, and then I went to cath lab, and then I went to CVICU, and then I went over to a regular ICU, which was not fun because I like CVICU, and then I went into quality improvement. And so, I mean, in nursing on the floor, you're always looking at ways to improve things or make things better, make flow better, get yourself more prepared for certain patient situations or whatever it may be. But when you get into quality and you start, my first quality improvement project was when sepsis came, when the big sepsis, whatever that's called, came out, and everybody was trying to meet all of these requirements about getting antibiotics within the patient with 1 hour and pushing all these fluids. And, some things as nursing, you're like, oh, I don't know. But I don't know if that's the best thing. Like, you're thinking of this terrible patient with heart failure and you're pushing all these fluids on them because they have sepsis, and you're like, oh my gosh, did I just do something really bad? Or I think the best thing that helped me feel comfortable with it is that in addition to talking to my other peers and learning about what they did, and I didn't have a community like this to engage with. I did a lot of my own research to really understand, what are some things within the hospital setting that are impacting sepsis, or not just causing it, but the delivery of care or the delay in delivery of care. What are some things and what are the costs? And I did a lot of research like that, and you'll be surprised what you can find on the internet, just to educate myself on it more, because my thing was CV surgery. I wasn't a ID nurse, or I was doing CV surgery. So what the heck did I know about sepsis? But I think that, that might be also very helpful, is to try to learn as much about it as you can, make yourself educated on the topic about what we're talking about, post-operative events and readmission rates after post-operative events. Read that article from Michigan about post-operative events, readmission, length of stay, and see if there's other articles out there. Look up the authors. You'll find a lot of information out there that'll be very helpful to you in just making you more comfortable in the subject alone. So when you do talk to somebody about it, you don't have to necessarily be an expert, but so you're confident in what you're saying and engaging with that person. And so you come across, that confidence you have comes across in a way that they want to continue listening to you and realize that you recognize the problem or want to be part of the solution. So, okay, stepping back down. I'm gonna go on mute now.
No, you're fine. And Ruth just put a link to that article that you were referring to for the Michigan Collaborative. That's the one, Ruth, right?
Yes. And let me try to find Dr. Brown's paper real quick too, and I'll drop that link in the chat as well. Yeah.
Nancy Honeycutt, do you remember your first quality improvement project?
I do. It was actually around surgical wound infection. It was a pretty big project. It involved a lot of, it was multidisciplinary, because when you think about what you're trying to impact, a lot of different hands touch the patient. So we had nursing was the main player. Nursing, infection control, our infection prevention partners were a huge help with that. The surgeons, our advanced practice providers. So we had a really good team. Pharmacy helped us with that. And we were very successful. We changed a lot of things. The way we took care of our patient, everywhere from the prep for surgery to the preoperative shower, which ended up, that changed. And it had to touch so many different departments. You had to reach the outpatients, the patients who were coming in for same-day surgery. You had to deal with inpatients, and all of those people who were getting patients prepped for surgery are different people. So we had to do a lot of communicating throughout our service line. We involved the office staff. It was, a lot of education that you probably wouldn't think about initially when you embark on a project. We ended up changing our dressing post-operatively. Antibiotics, we made sure we were following best practice. So it was a very involved project, but it was successful. So
Awesome. And actually,
Yep.
that kind of leads us into our next question. Which is great, Nancy. It's perfect. Like, it's a great, but the best segue.
awesome.
Does your site have routine multidisciplinary meetings to review your outcomes? And it might help if I launch the poll.
Having multidisciplinary meetings is so important. That's probably one of my soapboxes.
Yeah. I mean, you really have to connect with each other, be on the same page with your teams. I
Yeah.
think that was for the sepsis one, that was a big one, making sure pharmacy realized how important it was to get the orders done, how important it was for lab to get the lab results done. And it kind of has to be a fine-tuned, well-oiled machine.
Exactly.
So let's go ahead so yeah, it looks like about 62% of us do have those meetings to review the STS outcomes. Nice.
And the other part of that question is, are your surgeons part of that team?
Oh,
I found that if you have a surgeon champion for your project, that it goes much smoother.
didn't show the
In
results.
my experience.
I would
I
agree.
agree. Yeah, I agree with that. I think the physician champion, in my case for sepsis, or the surgeon champion for any of our national quality improvement projects, I think is really important. You get a lot of buy-in. They will offer, and they'll be thoughtful about it. They'll offer up some ideas. Then they also get to see if something's not working and they're a part of it, they feel that they have more control over the outcome. And they take more ownership of something not working right. So instead of you initiating something and not engaging surgeon leadership or your surgeons at your hospital or other physicians, and then telling them, hey, this isn't working or we're getting bad results, they're going to come look at you, right? They don't feel that they have ownership. They're going to say, oh, well, you didn't implement it right, or you didn't do this, or you didn't do that. But when you get all of their input, all working together, it's the shared ownership of it. Gets it out of pointing fingers at who did not do something right to the point of where you're saying, okay, this isn't working for us. How do we make it better so we get good outcomes? And you kind of get over that whole hump. Did you experience that too, Nancy? Because I did. If I didn't loop in my physician leader, even now at STS, if I don't loop in something, it's easy. Or if I'm not looped into something, it's easier for me to say that the other person didn't do something right because I wasn't involved. Whereas if I'm involved with something, I have,
Well,
I feel like I had a little bit more control in the situation, and I probably could have done something better instead of me just pointing the finger at somebody else.
right. No, I agree with that. I agree. And our surgeons, they want to be successful and have great outcomes, and they want to participate in your projects.
Yeah.
And it's a like we've been talking about, it's a team effort for sure.
Yeah, but don't tell your surgeons they have bad outcomes.
No.
Maybe start off a little bit softer than that. I don't know.
Don't say that.
Well, Carol and Nancy, thank you so much for the discussion. I can see how that would go over like a ton of bricks.
Yeah.
So I know we've been talking, for Q&A, and that we've gone through, many of the questions. Here's a next, Mindy, she's like, what is the next step? What readmission processes are we putting in place? Are they ones from STS or ones we come up with ourselves?
So we are going to start digging into the postoperative events one by one, not all of them, obviously, but we're gonna hit the high points on some of the postoperative events and talk about some ideas on how we could think about quality improvement for those postoperative events, which should theoretically then reduce readmission rates. So you're also welcome to just dig into this on your own. If you've got a lot of quality improvement experience, and if you want to share with the project with your surgeons and say, hey, we're looking at readmission rates, focusing on individual postoperative events. I've looked at our data and it looks like our top 4 are, and I've looked at these articles and I think maybe what we should think about is A, B, or C. By all means, feel free to jump in with both feet. But we will be moving through it in a more structured process as a group as well. And would love to tap into the expertise that all of you have improving outcomes at local sites for specific postoperative events. So we'll share what we're going to talk about in advance.
Laura says, during their monthly case review with their surgeons, the question came up about air leak greater than 5 days. If a patient goes home with CT due to air leak, do we capture this as an air leak, or do we just capture if they remain in the hospital?
They're captured as an air leak greater than 5 days. If they go home like on post-op day 4 and they come back to your surgeon's office on post-op day 10 or whatever, and the air leak is gone, you have to capture the air leak greater than 5 days because you don't really know if it was or wasn't there at 5 days, so you're required to capture it. Were the graphs for the entire harvest period or just the past 6 months? My understanding of the data that Paul pulled was that it was for the entire harvest period. Did you interpret his communication the same way, Leanne?
Yes, yeah, it was for the entire harvest period. Samara, of the patients. Yeah, go ahead.
I was saying, of the patients that are readmitted, how many were sent home with home health care? There are times that a home health nurse can catch the early signs of a complication and prevent rehospitalization. I think that's a great question and something that we can certainly dig into in the future. I think another thing that I know we did at our site is that we send our patients home with like I want to say like a warning t-shirt, but it's not really a warning t-shirt. But when they go to the emergency room, they're told to call their surgeon before going to the emergency room, because sometimes the surgeons are able to prevent readmissions because they have a better understanding of what's normal in the postoperative period versus what really requires a readmission than perhaps an APP or a physician that's less familiar with the usual postoperative course. And so I think that's another thing that sites have done with some success to reduce readmission rates, but it's definitely multifactorial. Great question.
Kelly had asked if there was a plan to include readmission rates in the risk adjusted report. And I was actually just replying to her. I'll bring this back to surgeon leadership for discussion. I think it's, a great idea, and we can look at adding it into future reporting, but it won't be included in, the next upcoming report release.
I would like to say, Leanne and Ruth, you did a great job on this webinar and a great job picking the date, because we were just notified in our STS Data Manager Facebook page that this week is Quality Week, Healthcare Quality Week.
Oh no.
So strong work picking the date for this start of this big project.
So
You
Mary,
didn't even know.
I know. Look at us. So is there going to be a webinar in the future, like the one canceled on 9/20 in the future. Maybe I missed it. The September quality improvement. Yeah, we had to cancel the September. So we, actually, my next slide, Mary. Our upcoming GTSD webinars, our monthly webinar, November 13th, is at 2:30 Eastern, and then our December monthly webinar is the 11th. So our quality improvement series. So our next, I looked at the calendar. Our next quality improvement for November is actually scheduled for Thanksgiving Day. So we are working to schedule the next quality improvement webinar early December. I'm looking at the first 2 weeks, and I'll work with Carol and Emily to get that nailed down. I'm also working with Dr. Brown. Hopefully we can have Dr. Brown come and present to us on that December webinar. So we will share that date. Marketing will share information about when the next quality improvement webinar will be. But again, I'm looking for the first 2 weeks of December. As we know, the latter part of December, we're all busy. So we will share that date, and also I will share that date on our November 13th webinar as well. So it will be solidified prior to that November 13th webinar. So that information will be coming. But again, we can look for those first 2 weeks of December for our next quality improvement webinar. Like Ruth said, we're going to do a deeper dive into the data. We're going to be working with our database research team and getting some good statistical analysis on some of them that are data for the next webinar. Let's see here. We would teach patients, Samara said they would teach patients to call the home health care nurse before calling 911. Let's see here. A webinar explaining, so a question was specific enough, a webinar explaining the readmission QI project. Oh, Mary, okay, you just wanted, okay, yeah, here, let me unmute you. Hey, Mary.
Hi there, can you hear me?
Yes, ma'am.
Hi, I apologize for not being clear. So when you guys first introduced this readmission QI project, you said there would be a webinar like in September 20th explaining it, and I was going to show that or give the link to the surgeons I work with and the PAs and other leaders. But then it was canceled, so I didn't know if there was one to replace it or did I miss it?
Or you're on it right now. Hold on. Sorry. Hold on.
I think we had another, I don't remember the date. Hang on.
Yeah, we had the kickoff call.
Yeah, what date was that?
I think
Were
that
you
was on the 9th. I think you did it on the monthly webinar on October 9th.
Okay, sorry, Mary. It's been a long day and my brain is completely fried. But yeah, let me look back at those dates and then I'll send you what we have. And there also the webinars that we've previously had, we had one other, the kickoff call was held and it was posted out on the website. And I can send you the link to that, or actually I can show you where it's at. Hold on.
Actually, I do have it pulled up, the previous ones, and I just have the GTSD quality improvement webinar was August 29th.
Okay.
And then
Yeah,
I
August
don't,
and the September, we were going to start looking at the data in September, but
Right.
we had to cancel that one. So today's webinar is, basically like the September. So we've had that initial kickoff call, and then this is our second webinar. And then,
okay, great.
yeah,
Well, I
yeah.
will
Yeah.
show what you guys have. Is there any way to know what our assigned number is?
Carol says no.
Ruth can
But you
email you
should-
that out separately.
Yeah.
Oh.
Yeah. So if you email Ruth, or you can email myself, but I think Ruth has here.
I have them, yes.
sts.org. So there's Ruth's, my slides presentation disappeared. Sorry about that. And so, oops.
If you
And I
email
wasn't
me-
trying to be smart, Mary. I was just joking when I said I think you're on it now. 'Cause
I got it, Carol.
Okay.
Thank you. I was
Okay.
thinking, like this sounds like a good one, but I wasn't sure.
If you
Like, I don't think we did another webinar,
if you
but you
email
know,
me asking for your, oh, sorry, go ahead, Carol.
no, you're fine. Sorry, Ruth.
I was just gonna say, if you email me asking for your number, can you please tell me what your participant ID is? Because I don't know what data manager belongs to what participant ID site. So you would have to tell me that.
Yeah. But Kelly said she'd also love to see, who was discharged to home in the risk adjusted report. Kelly, can you do me a favor and just email those two suggestions to the STSDB_helpdesk@sts.org. And then we keep a list of report enhancements requests from our participants, and we go over those, each month. So if you could send that request to add those metrics to the risk adjusted reports, we could get that added to our list, and then we can review it and talk to the surgeons, and then, possibly, work and to get that added into the reporting. So again, just shoot that to STSDB_helpdesk@sts.org. And Amanda, I know we're a little bit over, so one last question about the new thoracic risk scores. Will these be used on every lung cancer resection and every esophageal cancer, or every esophageal resection case from this point forward, or is this elective by our surgeons? So are you talking about?
You're talking about the risk calculator. I think you're talking about the risk calculator that was just published. Are they required to use it, or is the surgeon just able to use it if they choose?
Yeah, it's not, I can take that one. I'm
Yeah,
sorry, I
okay.
don't see the question though. Hold on, I just want to make sure I don't.
Yeah.
So the what's interesting about these new calculators that just came out is they are for primary lung and esophageal cancer. They are more inclusive, I'm sorry, and that they can be used for emergent and non-emergent cases. They have they aren't required, but they are part of shared decision making, which is important to CMS. So I wouldn't count out them not being part of some type of CMS thing in the future, not knowing what that is or what CMS does, but I just be aware of that. I strongly, if your surgeons haven't received the STS email yet, or if they've been haven't had a chance to look at them yet, I encourage that you go out and work with your surgeons so they know that they're available. I did have a little bit of a question about the language that we use to call the risk calculators in the STS news that went out. It referred to them as general thoracic. So I would just remind your surgeons that they're for primary lung, primary esophageal cases. They are for analyzed and non-analyzed primary lung and esophageal cancer cases, meaning that they also include cases that are not just elective cases. They can be used for emergent, non-emergent or salvage cases. Regarding the shared decision-making thing, if that is important to the surgeon and the patient that they're caring for, I think it's something that you would want to encourage your surgeons to use. They can have their the APAs use that when getting the patient ready to see the surgeon for their consult. It could be done in the hospital, only takes a few seconds to do. The website is mobile friendly, so they can bookmark that link onto their home screen of their smartphone, which is pretty simple to do. So instead of, you don't have to download a whole nother app, you just bookmark the website, and you could do it on the menu at the bottom of your screen on the web browser. There's a thing there to bookmark it and save to home screen.
Mhm. And also, our Hot Topics webinar is next week. It's on Monday. So for everyone that attended AQO, our in-person and virtual attendees, our Hot Topics webinar is Monday. I should have put that on the upcoming webinars slide, so I'll add that before we post the slide deck. And Dr. Cedar, fingers crossed he'll be out of the OR in time. Hopefully he will be, he is on the schedule, and hopefully he'll be going through the new risk calculators, showing those as well.
Yeah, he'll be really good at explaining what's in there and how to use them. They are very fascinating. They have confidence intervals on them. So for those high risk patients, or lower risk patients. Sometimes risk models in general are not super reliable when you get to the very high or very low end of risk. So having the risk confidence intervals in there gives you a better understanding of where that patient might fall risk-wise. It's great for shared decision making. We all highly recommend it. STS and STS surgeon leadership highly recommend that they start getting instituted. They are not required. We do not have a field in the GTSD data collection form that's asking if the risk calculator was used and discussed with the patient like we do in adult cardiac, but I can't guarantee that's not going to be added. If it is added, there's no requirement to use that risk calculator right now. Besides, shared decision making is pretty important in patient care. So.
All right, well, we have gone a little bit over. So let's see. There's one last question. Would the new risk model hot topic or any education on it ever be available for those of us who couldn't go, unable to go to STS in person or virtual? Or is it just for those who pay? Oh, yeah, we, actually, I did all of the information about the revised risk models, will be included in the report analysis overview, that's released with the report. Also, I did a presentation just briefly going over the revised model and what changed. And I don't remember the date of that off the top of my head, but if you email me, I can send you a link to it and let you know which webinar it was. But we'll have more education, and Dr. Cedar has presented on the revised models as well, so I can give you more information on that. Just email me directly. All right, thanks everybody for joining today. Again, we look forward to having you all on our next December quality improvement webinar. I'll share that date ASAP. Thank you, Carol, Nancy, Ruth, everyone, for the phenomenal conversation. It was a great call today, and I appreciate you guys very much.